All right, 12:05 on my clock, so we'll get started. Uh, Thank you for joining me today. Very happy to be here to talk about asthma biologics. Uh, I know that it's March break, and many of you who are now watching this, might be watching it after the fact. So thank you for looking at the recording. I picked this title. It's a mab world, or how I learned to stop worrying and love asthma biologics. I was saying to my wife, I'd love to do grand rounds or a presentation where everything was a play on movies from Turner Classics. And she said to me, she says, no one will know what you're talking about. She said, you're old. No one will know what you're talking about with respect to Turner Classics. So I figured I might as well just at least have some semblance of this in my title. For those of you who are interested, it's a play on two very old movies, but very good. It's a mad world, but now it's monoclonal antibody world, and Doctor Strangelove, Peter Sellers and George C. Scott. Doctor Strangelove, or How I Learned to Stop Worrying and Love the Bomb. So two very good movies that you could see on Turner Classics if you so desire. We're going to talk about some take-home points first from this presentation. And I'm going to share with you over the course of this grand rounds that asthma biologics are life-changing medications that prevent and for some eliminate asthma exacerbations, eliminate the need for prednisone. They also improve lung function, enhance quality of life, and for some resolve fixed airways obstruction. But you've heard me speak about prednisone before, and I'll say it again. Prednisone in the setting of exacerbations is a necessary evil. More is not better. This is not vasculitis. More prednisone, higher dose, greater frequency, even in the ED, does not further attenuate the consequences of type 2 inflammation any better than less or enough. Like radiation, there is no safe dose. The consequences of prednisone, as I'll show you, are indelible. When you give higher doses of prednisone, you're not doing anything for the underlying inflammation within the lining of the airways. You're not doing anything for the underlying inflammation that's taking place within the airways. You obliterate an element of underlying eosinophilic inflammation. And by obliterating eosinophilic inflammation, the ongoing process that drives inflammation within the airways stops. But the inflammatory material that's there, that takes time for the immune system to disassemble, break down. That's not steroid responsive. That's the collateral damage. The bomb's already gone off. Respirology can initiate biologics in the setting of severe asthma with an exacerbation history. I need four things from you. I need an asthma diagnosis. I need the patient to be on a high-dose ICS with a LABA. So this is your friendly Brio 200, Symbicort 200, Zenhale 200, Advair or Wixela Discus, the 500, Advair MDI, the 250, Atectura 320, or high-dose triple therapy. And you probably see us on the consult service starting Enerzair 160 in hospital because we have it on formulary, Trelegy 200 in an outpatient setting. Patient needs to be on a high-dose ICS LABA. All they need is one exacerbation. And then let respirology phenotype, let us take it from there, and we will be able to initiate a biologic. When we're looking at the characteristics for asthma control, every asthma presentation has to have this. The threshold is high. A patient with asthma should be able to live life where they do not feel and are not reminded that they are asthmatic. Daytime symptoms at the most, we would allow 2 days a week. Nighttime symptoms, zero. Here it says less than one. Less than one, of course, is zero. Nighttime symptoms, you should be able to sleep through the night, not wake up at night at all, feeling symptoms of uncontrolled asthma. Cortisol levels will be at their lowest in that 2 a.m. to 4 a.m. window. Circulating adrenergic compounds, similarly at their lowest level at that same period of time. You need cortisol to maintain beta receptor tone. You need adrenergic compounds to maintain beta receptor activity. Both of those compounds at the lowest level in the 24-hour cycle. Nighttime symptoms are common for uncontrolled asthmatics, more so than, for example, sometimes daytime symptoms. Nighttime symptoms, zero tolerance. Physical activity normal. Exacerbations at the most should be Ventolin only, and a couple of times a year. That's it. Few days of extra need for Ventolin, perhaps due to ozone, a viral respiratory tract infection, or something that is an environmental trigger. No absenteeism, and need for Ventolin should be at the most 2 doses per week. I have the luxury, as do most of our respiratory colleagues, of having lung function at each visit. I can tell you that when all of these 6 criteria are met, lung function is 90% or more of their personal best, or it is normal. The key question to ask from an asthma control perspective, if you want to break it down even three criteria, it's nighttime symptoms, reliever use, and activity. There should be nothing that they have to avoid, deviate from, or change or alter because of uncontrolled asthma symptoms. They should be asymptomatic. The challenge, though, is that uncontrolled asthma symptoms increase the likelihood of exacerbations. Uncontrolled symptoms means uncontrolled airways inflammation. Airways inflammation leads to exacerbations. Here we're following three cohorts of patients, age 18 to 24, 25 to 39, and over 40 for 20 years in the United Kingdom. And we're looking at the impact that asthma exacerbations have on lung function. Those in green and gold have a higher frequency of exacerbations per year. They have an accelerated decline of lung function, and that accelerated decline of lung function holds for the younger, mid, and older age group. But I want to focus on the 18 to 24 at baseline. These young adults with uncontrolled asthma, sure, they're young. They have a lot of physiologic reserve, but look at the slope and trajectory of decline of lung function. It is far steeper for the frequent exacerbators in that cohort versus the older cohort. At the end of the day, just because you're young doesn't mean that you should tolerate uncontrolled asthma symptoms because you have reserve, yes, but every time you have an exacerbation, you will chew up your reserve. And life, you start with reserve. And if you exploit it, if you exhaust it, you enter middle and older ages where that reserve is gone. And now you have permanent lung damage. You're 44, 45, and you say, I fundamentally cannot do my job anymore because of respiratory symptoms. That is trajectory and life altering. Younger asthmatics with uncontrolled disease become older asthmatics with permanent damage to the lungs, and that has tangible respiratory, quality of life, and also socioeconomic consequences. So we can't take youth lightly and say, you have reserve, you can chew it up. That is a significant negative consequence because it catches up with you over time. So we have a patient with uncontrolled asthma, recurrent exacerbations. They have a decline in lung function with the passage of time. This increases their risk of mortality. This is a 25-year prospective study of adult asthmatics. Normal lung function is the reference group. The y-axis is relative risk of all-cause mortality. The greater the severity, mild to moderate or severe impairment of lung function, the greater the likelihood of having an increased risk of mortality over 2.5 decades. Uncontrolled symptoms means uncontrolled inflammation, means increased risk of exacerbations, means an increased risk of mortality. And what do we do when a patient has exacerbations? We give them prednisone. It's a necessary evil. It's a double-edged sword. But there's an emerging concept in respiratory medicine that each dose of prednisone has permanent consequences to the patient. And here I have many comorbidities highlighted. And patients are stratified based on low, medium, and high use of prednisone. Low use, less than 500 milligrams. Medium use, 500 to 2,000 milligrams. Patient coming into the emergency department with an asthma exacerbation getting 125 milligrams of Solumedrol Q8. By the time I see them in the morning, they've had about 375 milligrams of prednisone. Now, they're going to require another 4 or 5 days of 40 milligrams of prednisone. So we're now already at 575 milligrams of prednisone. One ED visit, you're no longer low use, you're medium use, just from that first visit. How long does it take for a patient to get referred to respirology to start biologics? 2, 3, 4 exacerbations? The data demonstrates generally no less than 3. Add this up. Permanent consequences of prednisone for any comorbidity that you see listed here. And what happens when you correlate mortality on the y-axis? This is not risk of mortality. This is cumulative percentage mortality. And prednisone use, the various lines, and 20 years on the x-axis. Well, medium and high users of prednisone compared to non-users of prednisone have a significantly increased risk of mortality. If you're an asthmatic in this Danish cohort and you've never had to ingest prednisone or have it injected into a vein via intravenous, you have about a 3% mortality at 20 years. If you've used more than 2 grams of prednisone in your life, you have about an 18% mortality risk, 6 times as high. These are indelible consequences, and this is where biologics play a role. We have 6 biologics available to us. Realistically, we only have four because Xolair was approved, omalizumab, back in 2004, and it has fallen out because while it was very effective at the time targeting IgE, we have better biologics that target multiple pathways that cause elevated levels of type 2 inflammation in the setting of asthma, leading to exacerbations. Mepolizumab, Nucala, anti-IL-5, approved by 2015. Benralizumab, anti-IL-5 receptor in 2018. Reslizumab was an anti-IL-5. It's an intravenous drug. Unfortunately, that was dead in the water when it came to market. It's intravenous, very difficult to use in real life. And then Dupixent, Dupilumab, anti-IL-4, IL-13, the focus of today's presentation, and Tezepelumab, Tezspire, anti-TSLP. What is unique about Dupixent, Dupilumab, is that we can prescribe it in Ontario after just one prednisone requiring exacerbation. For tezepelumab, benralizumab, and mepolizumab, it remains two prednisone requiring exacerbations. So let's look at the data. How do the phase 3 trials inform on what biologics can do for eligible patients? This is Nucala, mepolizumab, the first to come to market. This was published in the New England Journal back in 2014. I'm going to focus a little bit on table one. Let's go back in time to 2014 to see what a severe asthmatic looked like at that time. Well, around 49, 50, majority female in this study, elevated overweight BMI, minority former smokers, about 27%, but they've been living with asthma for 20 years on average. 25% of them were on chronic prednisone. Think about the last time you saw a patient on chronic prednisone for asthma in the modern era. Not as common. And in this study, for severe asthmatics, 25%. Average dose was 12 milligrams. Their FEV1 was 61%. In terms of exacerbations, this is the heartbreaking part at the bottom. On average, 3.5 severe exacerbations, hospitalizations, 5% intubated in the previous year. Status asthmaticus doesn't happen as often as we saw in the past. Inhaled therapy has dramatically reduced this. Biologics have dramatically improved management of underlying asthma. But chronic prednisone requiring asthma, that was the norm back then, unfortunately. And what did Nucala do? A 53% reduction of asthma exacerbations in clinical trial. Well, what about Fasenra? Followed 2 years later. Table one was similar, about 3 exacerbations per year, 51% reduction of exacerbations in the Sirocco clinical trial. What about Dupixent in Liberty Asthma Quest? Now, this was published in 2018. One of the interesting things to note about this study is that, look, the number of exacerbations was actually a little bit less, but 2 exacerbations per year. And about 50% of patients were on high-dose ICS. The other half were on medium-dose ICS. In just 4 years' time, we've seen a change in table one of what severe asthma looks like. Actually, biologic eligible asthma moving not necessarily from the severe prednisone requiring group, but to more patients on medium high dose ICS LABA. So relatively mild, still severe, but relatively mild compared to 12 milligrams of prednisone daily. I think you'll agree with me on that point. And still, 48, 46% reduction for 2 doses in this randomized controlled trial. And in the most recent, Navigator. Navigator published in 2021 in the middle of the pandemic, hard to run a clinical trial in the pandemic. 75% of patients were on high-dose ICS. Only 9% of patients were on chronic prednisone, and a 56% reduction of exacerbation. This is huge. Remember that these patients were on potent inhaled therapy, managed at quaternary care centers during the clinical trial, and in the treatment arm, we saw a 50 to 60% reduction of moderate to severe exacerbations. That's massive. The way that these biologics work is they target what for some of you might be triggering from medical school, and for some of you, depending on your vintage, this type 2 inflammatory confusogram of cytokines may have had fewer populated cells back when you were in medical school, because of course we have new pathways that have been discovered that lead to inflammation. These are the pathways that are targeted. When you explain to biologics to patients with asthma, you can tell them that these are not steroid injections. There is nothing steroid or immunosuppressive about these drugs. In fact, the safety profile is quite reassuring that we have no short-term or long-term serious or major adverse effects. The pain and discomfort of having a subcutaneous injection is all that most patients will feel. Side effects are rare because what they do is they block those pathways that are elevated in severe asthma, this inflammatory allergic, what we call type 2 disease. Most of the biologics like Nucala, Fasenra, and Dupixent operate in this middle range of blocking key cytokines that are responsible for the allergic and eosinophilic pathway. Where things are emerging, and the newest biologic on the market, tezepelumab, Tezspire, actually blocks higher up, blocking that alarmin, that airway's initial trigger that causes downstream pathways to be activated. I could spend an hour just talking about these pathways. I will spare you that. But I will tell you that these pathways are key in not only causing exacerbations, but also the downstream remodeling and changes that we see in asthma, laying down collagen, laying down increased production of fibroblasts, increased smooth muscle hypertrophy and hyperplasia, causing that fixed airways remodeling that we are very fearful of in the setting of uncontrolled asthma. So in terms of criteria, for a patient to receive a biologic, they need to be on a high-dose ICS plus a controller. Brio, Symbicort, Zenhale 200, Advair 500, Wixela 500, Advair 250 MDI, Atectura 320, or triple therapy like Trelegy 200 or Enerzair 160. Of course, that patient consulted in the emergency department will be seen by Respirology when they're admitted, and Respirology will escalate this patient so that they're on a biologic eligible controller. We also need to see elevated eosinophils, generally 0.3 or higher, and this can be in the previous 12 months. What's interesting about Dupixent, and we're very pleased that the EAP in Ontario has permitted this, is that the clinical trial for Liberty Asthma Quest for Dupixent only required one exacerbation. So that's all that's required. One course of prednisone in your office, in my office, or in the emergency department, and eosinophilic threshold very low at 0.15 compared to 0.3. So let's start with a case, and I'll show you the benefit of biologics over the course of two cases. A short case here, just summarizing what biologics can do and how patients feel, and then some of the data behind Dupixent, and then finishing with a very nice case, a very satisfying case of severe asthma. This gentleman, 48 years young, severe asthma, on single inhaler triple therapy with Enerzair and Ventolin, significant bronchodilator response despite potent high-dose triple therapy inhaled therapy. Pan-allergic, allergic to the world around him, has chronic rhinosinusitis. He's on nasal saline rinses, Nasonex sometimes twice a day, and Blexten every day. Complete anosmia, can't smell a thing. Works in a factory setting where he's a machine operator, and we did discuss that the anosmia can actually be a significant risk for his job. He didn't tell his employer this because he uses various chemicals, and those chemicals have to be completely evaporated before he starts his machine. So he kind of relies on just timing as opposed to being able to smell that the chemicals are gone, like most of his colleagues. It is somewhat dangerous because they are flammable. No acid reflux, IgE was elevated, so clearly has an allergic phenotype. Eosinophils were elevated. He was on Nucala in the past, from 2020 to 2022. He continued to have exacerbations on Nucala, and unfortunately his insurer said, "You're exacerbating despite this biologic, we're going to stop coverage." He was given prednisone in late 2023. He was referred to me by his PCP. He had labile symptoms, wasn't in an exacerbation when I saw him. I started him on Dupixent. He met the criteria: severe asthma, elevated eosinophils above 0.15, had an exacerbation in 2023. I pulled the trigger on the consult visit. And oftentimes when these patients are set up in this way, high dose ICS with one or two more controllers, elevated eosinophils, they've had prednisone, I can pull the trigger on the consult visit. Forget about a follow-up. We can do it first visit, get them started on drug. 2 months later, see him in follow-up. This is what he said to me, summarizing this from my note. Dupixent has been life-changing. He thanked me again for saving his life. I didn't actually save his life. I just improved his quality of life. His words. His nose is completely clear. His sense of smell has returned. He doesn't use Nasonex anymore. He doesn't have to use nasal saline rinses. He doesn't require Blexten. He has not had any symptoms of uncontrolled asthma. Doesn't need Ventolin. Hasn't required prednisone. Of course, it's only been a few months. and he remains on Enerzair. He's gone from requiring nasal rinses, Blexten, Nasonex, Ventolin, and Enerzair to just Enerzair and an injection that he can do himself at home. Dupixent has a number of indications in Canada in chronic inflammatory disease with type 2 inflammation. It started with atopic dermatitis, and some of my first experiences with it have been patients with bad atopic dermatitis who came to me and their skin looked fantastic. And I looked at their spirometry and it had a huge improvement compared to prior. You'd, it's for young adults, having bad atopic dermatitis is a socially stigmatizing, very visible manifestation of type 2 disease. And just the fundamental improvement that they've had in their quality of life, their interaction with others is astonishing and amazing, truly a credit to the drug. Well, indication of 18 and over became an indication for 12 and over. Then chronic rhinosinusitis with nasal polyps was added. Then asthma was added for those 12 and older, atopic dermatitis for age 6 years, asthma for 6 years or older. Now, atopic dermatitis for 6 months and older, an infant indication for atopic dermatitis, giving you a reflection of the safety of this medication. We should have a COPD indication quite soon because I'll show you some data at the end of the trial in the setting of COPD. Summarizing this for your reference, atopic dermatitis, asthma, chronic rhinosinusitis with nasal polyposis, and eosinophilic esophagitis. Systemic manifestations and organ-specific manifestations of type 2 inflammation, all of which Dupixent has an indication. Getting back to our patient case, one of the things that we've noted is that the type 2 disease that we're seeing in patients with asthma has a range of phenotypes. In some cases, we see an allergen-driven asthma component with elevated IgE and elevated fractional excretion of nitric oxide. That may not be a test that you're familiar with, but it's something that we have access to in the office, depending on availability, of course, to measure airways level eosinophilic inflammation. Some patients, on the other hand, are purely eosinophilic. Their blood eosinophils are elevated, their airways eosinophils are elevated. But like most things in life, it's never clean. The mixed phenotype in the middle is often what we see. Seasonal, perennial, allergic rhinitis, and allergic disease driving asthma, underlying eosinophilic inflammation from the very nuts and bolts of the immune system, leading that particular aspect of their immune system to be hyperactive, leading to worsening type 2 inflammation. That mixed phenotype is common. The extremes exist, but like any bell curve, the meat and potatoes is going to be in the middle. And there's overlap in this, and there's data to support this. At the bottom, in the ISAR, the International Severe Asthma Registry, 60% of patients had 2 or more elevated biomarkers, while isolated biomarker elevation exists for eosinophilic, allergic, and type 2 airways inflammation. There is a high degree of overlap. Multiple pathways are active at the same time. There are many targets that we have to focus on in the setting of underlying severe asthma in the office. And oftentimes we're focusing on the allergic component, the nasal component, the occupational component, the airways inflammation component, and trying to pick a biologic that also targets all of these pathways. Not that easy, but we're blessed with having new agents that can do just that, target multiple pathways at the same time with the same injection. So when we're looking at type 2 inflammation and asthma, this allergic, eosinophilic, airways inflammatory component, multiple diseases coexist. How do we target all of this at the same time? It is really focusing on the individual comorbidities, things that we've talked about in asthma management of treatable traits, but also targeting each of the individual underlying conditions with targeted therapy for the sinuses, for environmental allergies, for the asthma, and a biologic that wraps it all together with one injection that targets multiple pathways. I focus on nasal polyps because even though the case that I mentioned was chronic rhinosinusitis and he didn't have nasal polyps, patients with uncontrolled chronic rhinosinusitis can go on to develop polyposis. There are other pathologic features that make this more likely in one versus another, but they go on to develop underlying pathologic destruction of airway of nasal tissue, development of nasal polyps, and worsening nasal outcomes. It coexists with asthma. 80% of nasal polyps are type 2. They are pro-inflammatory with this eosinophilic allergic phenotype. And about 50% of patients with moderate to severe chronic rhinosinusitis with nasal polyposis have existing asthma. Makes sense. This is a united airways. The inflammation in the upper airways will correlate with inflammation in the lower airways. But 50 to 84% of asthma is type 2, this allergic eosinophilic inflammatory component. And up to 40% of those patients have chronic rhinosinusitis with nasal polyps. There is a link in the upper and the lower airways. So when we're talking about Dupixent and how it functions, the epithelium is where the action is. Allergens, viruses, and irritants attack the epithelium. The epithelium has alarmins, these key switches that are turned on to say to the downstream cells, something is going on here, you got to pay attention. That's TSLP, IL-25, and IL-33. Dendritic cells, as you know, they're the antigen-presenting cells of the immune system. They will pick up an antigen, they will show it to a T cell and say, hey, I found this. The T cell will say, good job. And the T cell will then activate IL-4, which is that pro-eosinophilic inflammatory cytokine. The dendritic cell then learns, when I see this, I need to show this. And the Th2 cell, which is now pro-inflammatory, says, I need to make more IL-4. Three cytokines inevitably are made. IL-4, which is pro-T2 inflammatory, IL-5, which is pro-eosinophilic, and IL-13, which induces eosinophilic epithelial level inflammation. All of this leads to systemic and local inflammation. From a systemic standpoint, IL-4 drives that eosinophilic basophil and mast cell, which are the allergic inflammatory aspects and arms of our immune system. Why do we have these cells? Parasites. These are notoriously effective in management of parasitic infections. Now, in an environment where parasitic infections are quite low, fortunately, these are usurped, co-opted, and you can insert your verb here of recruited to participate in this allergic phenotype. Things which our immune system sees less often, allergenic exposures. These cells drive eosinophilic inflammation and lead to worsening asthma outcomes. IL-13, however, primarily signals at the level of the epithelium and is responsible for mucus hypersecretion and also downstream, increasing smooth muscle contractility, smooth muscle hyperresponsiveness. These two compounds, plus IL-5, drive worsening aspects of type 2 disease. So Quest, the primary randomized controlled trial for Dupixent, which was published back I already showed you the punchline. Here I'm showing you the main trial in terms of its data and how we came to be. Looked at two doses of Dupixent of 200 milligrams and 300 milligram dosing. A primary outcome was annualized rate of severe exacerbations over 52 weeks. And another primary outcome was change of lung function from baseline to week 12. This is dosed every 2 weeks. So by the time you get to week 12, you have enough doses under your belt. All you were required to have is exacerbating asthma with type 2 disease, one or more exacerbation. Really summarizing the inclusion criteria here for you to make it nice and simple. This is what table one look like. Now, I've shown you little bits and pieces of it before, but I really want to paint this phenotype for you. 47 years young, average age, 63% female, FEV1 about 58%, so moderate asthma. Number of exacerbations in the previous year were 2.09. The second red box is that about 50% of patients were on high-dose ICS. This wasn't as severe as Nucala, where 25% of patients were on chronic prednisone. This was more of a moderate to severe phenotype. Again, this was published in 2018, as opposed to Nucala study published in 2014. 82% had an atopic allergic condition. 23% had nasal polyps or chronic rhinosinusitis. Eosinophils were elevated, IgE was elevated. This was the data. Intention to treat population, 46-48% reduction of exacerbations depending on the dose. But let's look at elevated eosinophils. Percentage-wise, the higher eosinophil group, 300 or more compared to 150, a greater reduction of exacerbations. Pheno, looking at epithelial level inflammation. The higher the pheno, the greater the degree of exacerbation reduction. We're talking about, for some of the sicker patients with elevated eosinophils over 300, elevated pheno over 50, 70% reduction of exacerbations. These patients are already on excellent quaternary level care for management of asthma, and still, compared to placebo, having a 70% reduction of exacerbations. That's huge. What if we look at lung function? Well, this is also surprising. We see a significant improvement of lung function, not surprising in itself, but the greater the degree of type 2 inflammation, eosinophils over 300, third set of columns, FeNO over 50, a greater degree of improvement of lung function. The more T2 you were in this study, the greater the benefits you extracted from Dupixent, the greater that needle is pointing towards type 2 inflammation, and that fire of type 2 inflammation is burning, the greater the outcome that you had when you were on Dupixent. So let's go even further. Let's go to those with an eosinophil count over 500. In our hospital, when you're in EPIC and you see eosinophil count 0.5 or higher in the setting of asthma, these patients, you see a 71, 74% reduction of exacerbations. The more T2 these patients were, the greater the degree of benefit they had from Dupixent. Those that are at the greatest risk, those who stand to lose the most in the setting of asthma, are the ones that had the greatest benefit when we started them on Dupixent. It worked, even for those with eosinophils of 0.15, even at the lower end of T2. It was phenomenal. But those with higher burden of disease severity, they extracted even greater benefit. This gives me comfort because asthma triggers, asthma inflammation is not constant, it's labile. And if I have a patient that I capture at one time of the year and they're relatively controlled, but I know they're going to deteriorate at another time of year, that T2 needle is going to flare. Having them on Dupixent means that when that T2 needle would be at risk of flaring, there's a greater benefit of that drug tamping it down, preventing that from happening. Because labile asthma, uncontrolled asthma, is the norm. It fluctuates season by season, month by month, trigger exposure by trigger exposure. This gives me comfort. There is no upper limit to the efficacy of the drug. And if we take that high eosinophilic phenotype and look at the improvement of lung function, almost half a liter of lung function improvement compared to baseline. Placebo benefits in clinical trial. Every patient benefits in clinical trial because they're in a clinical trial. But you get half a liter of lung function improvement. That is outstanding. Put this into perspective for most adults. We're looking at an FEV1, the amount of air that they can blow out in the first second is somewhere between 3 to 4 liters. And again, it varies based on age and it varies based on height and body size and body weight, but 3 to 4 liters or so. Here you see a 500 milliliter improvement. You can see that percentage-wise, that's a significant improvement of lung function. Well, it's not just the reduction of exacerbations, the improvement of lung function, but what does it do over time? Because these biologics, it's not just I give 1 or 2 doses and that's that. This is a long-term medication, and I'm very comfortable with this because the benefits of these drugs are long-term. This is short-term data from a 52-week randomized controlled trial, so this is efficacy. When patients were on Dupixent, there was a 0 milliliter decline of lung function in that clinical trial over the course of the year compared to placebo. Placebo deteriorated. In Dupixent, there was no decline of lung function. I'm going to move to our second and final case. This is a bit of a long case, but I want to highlight the length of this case to show you the journey of severe asthma in the office because these patients are fundamentally managed by respirology and allergy and co-managed with the family physician. But we're in the driving seat here. We're driving this journey. The takeaway from this case is we can tinker a lot in asthma, but tinkering leads to morbidity and harm. If the patient is biologic eligible, we need to pull the trigger. There's also better characterization and phenotyping of the patient that is required by your friendly neighborhood respirologist to make sure that they're on the right biologic. And you'll see this through this case. I'm not in favor of tinkering through much. Aggressively escalate, place this patient on high dose therapy, and my preference is single inhaler triple therapy from the beginning because they're at high risk of exacerbations by the time they see one of us, either in the ED, in the clinic after an ED visit, or my office, and initiate biologic that has broad coverage of type 2 disease when they meet those eligibility criteria and give them time. they'll meet the criteria. This patient, 39 years young, immigrated from Jamaica in 1994. So that was about 16 years, 26 years before I had seen her. So immigrated when she was young. She has seasonal and perennial allergic rhinitis to cats, plants, dust, mold, and pollens. Her medications when I saw her in consultation were Flovent, Ventolin, nasal saline rinses, and Flonase. She was using Ventolin daily, on a daily basis. Working as a PSW in a retirement home, long-term care, living in an apartment, no pets, 15-year-old son, apartment was clean as possible. Look at the date, March 2nd, 2020. This was her lung function. It had been performed prior to the visit. She presented to the PFT lab at Centenary at the time, back in April of 2019, with an FEV1 of 49%, severe airways obstruction. She had a 31% improvement in FEV1. Moderate airways obstruction, FEV1 was 64%. Very important piece of information here, this number. Normal adult physiology is such that you should be able to blast out 70% of the air in the lungs in the first second. That's normal. Less than 70% is abnormal. Not only did this breathing test confirm asthma, but it confirmed that she still had moderate obstruction even after bronchodilator challenge. I know she is on Flovent and she's using Ventolin every day. Now I'm concerned she has fixed airways obstruction, scarring of her lungs. So what did I do? Well, we also looked at some other aspects of her chart. She had a CT sinus. It showed impaction of her sinuses with pan-inflammation of her sinuses and nasal polyps. We had PFT. We had chronic rhinosinusitis with nasal polyps. We had symptoms of uncontrolled asthma. So what did I do at the time? We focused on the drivers of asthma with respect to her sinuses, her allergies, her work. I gave her nasal saline rinses twice a day. I prescribed Avamis, a potent nasal steroid, started her on Brio 200, Ventolin, and gave her Blexten every day. Planned follow-up at spirometry in September of 2020. The 5-year anniversary of the pandemic, folks. You know what happened a couple of weeks after I saw her. The pandemic. Appointments were disrupted on both ends. So here's what happened to her. She left her long-term care home for the retirement home, as she could only work at one facility in the pandemic. You couldn't work at 2 facilities or more. The retirement home had better pay, better hours, but no benefits. She couldn't afford Avamis, Brio, or the Blexten. So her PCP switched her to Wixela, generic Advair, Ventolin, and an over-the-counter antihistamine. Unfortunately, this was a de-escalation, meaning that the nasal steroids were gone. The Brio had been de-escalated to a weaker drug, Advair, generic Advair here, and the over-the-counter antihistamine was de-escalated. This unfortunately had to happen because she literally could not afford the medication. So 2021 August is when I was able to see her again. She had had an exacerbation in June of 2021. In fact, she had had a previous exacerbation as well, 2 exacerbations requiring prednisone. Eosinophils were 0.5. Despite being on Wixela and Ventolin the night before her spirometry, there was a significant improvement. Look at what happened over here. Now, her baseline FEV1 was 52%, better than the 40-some% she had in 2019, and it went up to 75%, better than the 60-some% she had, but it was still a significant improvement of lung function, significant degree of uncontrolled airways disease. Compliance was a challenge. She was paying out of pocket. She wasn't biologic eligible due to compliance, despite 2 exacerbations. I tried to get her on biologic. I tried at that time, and unfortunately, her insurance company said not compliant. She had benefits, but had a significant copay. So we negotiated. I said, let's go back to the previous regimen, but at that time, we made it even more potent. We had nasal rinses, Avamis. I had Brio 200 and Incruz, open triple therapy with high dose, Ventolin and Blexten. You're probably wondering, why didn't I start Trelegy 200, single inhaler high dose triple therapy? Her insurance company didn't cover it. I have no idea why, but a cheaper drug that has all 3 compounds in one, they didn't cover, but 2 separate inhalers, they covered. I don't control the insurance industry, don't make up their rules, but she had to use multiple inhaler triple therapy. Despite this, had 2 more moderate outpatient exacerbations in September and October, despite good compliance. Likely these were viral, respiratory tract, and allergy related. So significant degree of uncontrolled asthma, another 2 exacerbations requiring prednisone. She was compliant. I was able to start biologic. I started Nucala. So her regimen was nasal saline rinses twice a day, Avamis twice a day, Brio 200 and Incruse once a day, Ventolin as needed, Blexten nightly, and Nucala injection every month. Hey, since starting Nucala, she didn't have to go to hospital. Exacerbations stopped, but lung function had deteriorated. Now, Nucala, as you know, blocks IL-5, one of the cytokines in T2 asthma. Not all, just one. Ventolin use was still an ongoing challenge. Lung function had deteriorated. Now, some of this could have been with respect to her inhalers. For some reason, Brio and Incruse made her feel a little bit queasy and unwell. Family doctor put her back on Advair and generic Advair, but also put Spiriva on instead of Incruse, so open triple therapy, but weaker compounds. Finally, she had a chance to see ENT for her nasal polyps. She was scheduled for a nasal polypectomy, optimistic for an improvement. Now, Nucala does have an indication in nasal polyps. It is not as potent in nasal polyps as Dupixent and one of the newer biologics called Tezspire, but the ENT was satisfied. I wasn't happy with her lung function at 41%, but we let some optimism play out and see how things go after her sinuses are controlled. So she had her nasal polypectomy. She asked me to have an urgent follow-up. Uh, Here's what happened. She didn't find that the biologic was beneficial. She had had her nasal polypectomy, but unfortunately, her asthma control, her symptoms, and her morbidity had not continued to improve after surgery. Surgery occurred. She felt better. And then she didn't make further gains. In fact, then the initial improvement was lost. The ENT commented that the polyps had come back. And unfortunately, there were other adverse effects with respect to her inhalers. She had to stop the Wixella. She was having tremor or tachycardia. I thought that this was probably more supratentorial as opposed to related to the medication, but she was switched again from Wixella to Zenhale, and Spiriva continued. She continued the Zenhale, but she stopped the Spiriva. She was on the Blexten antihistamine. She had replaced the Avamis with Rhinocort. You can see my frustration here in the notes that there was a lot of lateral moves going on, and we looked at the evidence of what's driving her asthma. Environmental allergies, irritant exposures in the workplace, working in long-term care, uncontrolled nasal polyps, uncontrolled upper and lower airway type 2 inflammation. Nucala had failed her, clearly blocking one cytokine in the distal end of the inflammatory pathway. Failed. We started Dupixent. Before I go there, look at the numbers on the right-hand side. Vital capacity 66%, FEV1 51%, airways obstruction, fixed airways obstruction here at 63%. We started Dupixent. I kept her on Zenhale and Ventolin. I said, fine. I said, let's just stay on Zenhale and Ventolin. Since starting Dupixent, she met all controller criteria. She had not required Ventolin. She did not have fluctuation of her respiratory symptoms. She continued with nasal Rhinocort. She continued with nasal saline rinses. The ENT had added Pulmicort nebules. But like my previous patient, sense of smell came back. She was able to stop the antihistamine. Look at the lung function on the right-hand side now. First thing to note, fixed airways obstruction, gone. Vital capacity and FEV1 in the 80% range. Normal lung function. Fast forward to 2024, exacerbation free since starting Dupixent. Lung function, further numerical improvement. During winter of 2023, she caught a viral infection. It started in her sinuses, sinus congestion, postnasal drip, some mild asthma symptoms. She was worried because this always went to her chest. She escalated her nasal rinses, used Ventolin for a couple of days. That's it. There was no exacerbation. She didn't require antibiotic or prednisone. When you are a controlled asthmatic, when you are a biologic controlled asthmatic, viral infections don't cause exacerbations. You get a cold, and a few days later, it resolves. This is her lung function trajectory from 2021 to 2024. Look at baseline ratio. Less than 70 indicates obstruction. Look at the magnitude of airflow in the first second. These three values before Dupixent, August 2023, after Dupixent. This is a phenomenal medication for maximizing airway caliber, obliterating airways inflammation, and controlling the pleiotropic aspects of type 2 disease that go beyond just those eosinophilic inflammatory cells and focus on the abundance of comorbid conditions that make type 2 biologic eligible severe asthma so brutal for patients. It was a 4 year journey from start to finish. And this is the challenge of the pandemic, but also the challenge of severe asthma with comorbid conditions, because there's always the feeling that there's something else that I can do, something that I can tinker with. We need to pull the trigger early and aggressively for these patients because biologics can work wonders, and not all biologics. I could have a 2 hour presentation to you, and please, if you want me to have a 2 hour presentation, just send me an email. Happy to arrange it. Of all of the biologics and the hard outcomes that they have, not all behave in the same way. And Dupixent and Tezspire, the two newest biologics, have more lateral reach of treating type 2 disease very effectively, as this patient case highlights. Going back to the 1 year clinical trial, Quest, and the 2 year follow-up study, I want to show you the journey that this patient is going to have as we get through 2025 and onwards. Patients in red were in placebo during the randomized control trial. Their lung function obviously didn't improve as much as those in green on Dupixent. But look at what happens when patients are switched from placebo to Dupixent as part of a 2 year open label study. Instantly, in 2 weeks, their lung function is at the level of the patient started on Dupixent for the previous year. There is no time lost. Lung function improves in line with those patients in the first 2 weeks, and there is no drop off. Unlike the Nucala experience that our patient case had, where after being on Nucala and having her nasal polyp surgery, things started to unravel and deteriorate again. The polyps came back. We don't see these signals with biologics such as Dupixent. And in fact, this is a complicated figure, but I want to just focus on the left-hand side here. This is fixed airways obstruction and the percentage of patients achieving resolution of fixed airways obstruction. Here, we're looking at a group of patients that have persistent airways obstruction. And here we're looking at those with elevated eosinophils greater than 150, FeNO greater than 25, and the sicker patients down here. Eosinophils greater than 300, FeNO greater than 25 at baseline. The green bar is Dupixent. The black is placebo. We see a doubling to a tripling of the number of patients with complete obliteration of fixed airways obstruction. That was our patient. She had fixed airways obstruction through her asthma journey, despite being on aggressive inhaled therapies, despite having many changes of inhaled therapies, and being on Nucala. She started on Dupixent, and we saw resolution of that fixed airways obstruction, obliteration of that obstructive pathology. 2 to 3 times more likely to occur when she's on Dupixent compared to placebo. It's not just the first 2 weeks, the first 6 weeks, the first 6 months. It is the long-term unraveling and reversing of the ravaging effects of type 2 inflammation. That's what these biologics are capable of. The last slide I'm going to close with is what happens with time, because it's not just the first year, it's beyond that. Placebo or Dupixent, in the year before entering the randomized control trial, patients on average had 2 exacerbations per year. Now, placebo did well when they were in the randomized control trial, had about a 50% reduction. But Dupixent had a 75% reduction of exacerbations compared to baseline. In fact, 1 year after the 1 year randomized control trial, when we get to year 2, patients continue to see a reduction of exacerbations on Dupixent. And even after year 3, continue to see a reduction of exacerbations on Dupixent. I've highlighted to you the impact of uncontrolled symptoms, meaning that they have uncontrolled airways inflammation. Uncontrolled airways inflammation leading to exacerbations of asthma. Asthma exacerbations leading to prednisone use leading to an increased risk of mortality, and highlighted all of the various aspects of type 2 disease that can cause asthma to decompensate and exacerbations to occur, and 2 cases where Dupixent was life-altering for the patient. You go from having 2 exacerbations per year prior to being on Dupixent to 2 exacerbations per decade. That is a phenomenal alteration and disease modification. This is the era that we're living in now. Respirology needs to see these patients. You prescribe prednisone. That is a patient that should be co-managed by respirology. Your friendly neighborhood respirologists are happy to help. There's a ton of us now through the SHN and in the community because starting these medications are life-altering. We've seen this in asthma. Earlier this year, I had a COPD presentation where we talked about Dupixent in the setting of COPD. There is more to come, but this is a very exciting time for respiratory medicine. I'm happy to take questions, but I appreciate it's 12:55. It's Wednesday. It's March break. So if you want to sign off, that's good. I'll hang around for 5 minutes. Thank you for your time today. And if you're watching this after the fact, please just go ahead and send me an email, and happy to answer any questions that you may have. Excellent. So there's a question here as to what's the cost of Dupixent. So for all of these biologics, the general cost is approximately $2,000 per month. All of them, Nucala, Fasenra, Dupixent, and Tezspire, are covered by the government. So the government, through EAP, covers the cost. If a patient has Trillium covers the cost. Of course, there's a deductible 4% of household income. They are also covered by private insurers as well. So access is not an issue, but generally out-of-pocket cost is about $2,000 a month. Uh, each biologic manufacturer has a patient support program that works with the patient as well as the government and private insurance for coverage. Each company also has a way of offsetting the out-of-pocket costs. So without quoting any numbers here, generally speaking, if the patient says, look, my insurance is 80%, I have to pay 20%. Sometimes they're able to say, okay, we can cover half of that 20%, so you only have to pay 10%. So this is tenable for patients, and it is manageable because the patient support program is there to advocate on their behalf. I figured it was Alexis. I said AG, so I figured it was yourself. Thanks, Tony. No, the impact of biologics in severe asthma, this is revolutionary, and we're entering a new era of disease alteration and disease modification. I mean, truly trajectory altering. I'll for the 12 who are here still, I will say that in the future, we will probably move to an era where we are initiating biologics earlier and earlier in the disease course. And I'll draw a parallel to osteoporosis. Back when I was a medical student, it was this large pill of reflux-inducing bisphosphonate that you took every Sunday with a giant glass of water and had to sit upright for 45 minutes, otherwise you'd have terrible reflux. Then it turned into a monthly pill. Then it turned into a twice a year injection. And innovation is moving to make that an annual thing. This is the evolution, going from high dose inhaled therapy to targeted pathway obliteration. That means the patient is less reliant on inhaled drug, less reliant on what is the standard of care now. That's the future. And that comes from evolution in clinical trial and expanding the indication to not as severe patients. We need the payers to follow. We need the government to follow because, of course, someone has to pay for this. But also with evolution, it becomes less expensive as time goes on. All right, folks, 12:59. I'm going to sign off. Have yourself a wonderful day.